Let's see about multiple myeloma and a few words about hairy cell leukemia in this video. So what is multiple myeloma? These are plasma cell neoplasms, which are B cell proliferations containing neoplastic plasma cells that secrete monoclonal immunoglobulins or immunoglobulin fragments. So these immunoglobulins and their fragments serve as tumor markers and often have pathologic consequences. Multiple myeloma, it's a malignant multifocal plasma cell neoplasm of the bone marrow, usually associated with M protein in serum and or urine. This is also commonly associated with lytic bone lesions, hypercalcemia, renal failure and acquired immune abnormalities. Multiple myeloma is the most common monoclonal gammopathy. So risk factors include genetic predisposition, exposure to ionizing radiations, chronic antigenic stimulation as a result of chronic infection and chronic inflammatory disorders like rheumatoid arthritis over the years, and exposure to chemicals like benzene, insecticides and herbicides. Pathogenesis. Multiple myeloma is genetically heterogeneous and is associated with rearrangements involving IgH locus on chromosome 14q32 and various other proto-oncogenes. Deletions of chromosome 17p involving TP53 tumor suppressor gene is also seen, and this is also associated with a poor outcome. Deep sequencing of myeloma genomes has identified frequent mutations of components of NF-kappa B pathway which supports B cell survival. This NF-kappa B is a nuclear factor kappa light chain enhancer of activated B cells. So, the factors produced by neoplastic plasma cells mediate bone destruction, which is the major pathologic feature of multiple myeloma. Then there is interleukin 6, which is an important growth factor for plasma cells. High levels of interleukin 6 is seen in serum of patients with active disease and is associated with a poor prognosis. The pathogenesis of the disease is as follows, which is activation of myeloma derived factor MIP1 alpha, which leads to increased osteoclastic activity, which in turn leads to bone resorption. So, bone resorption leads to lytic punched out lesions in the bone, and on the other side it causes hypercalcemia. So, moving on to morphology, multiple myeloma usually affects the bones of the axial skeleton. Next, these bones most commonly affected are bones of the vertebral column, ribs, skull and pelvis, etc. Lesions begin usually in the medullary cavity. They erode the cancellous bone, destroy the cortex and lead to pathological fractures. This picture here shows punched out lesions in the skull. Bone marrow findings, it is hypercellular. Presence of more than 30% of myeloma plasma cells is diagnostic of multiple myeloma. Plasma cells present as large oval cells with abundant pale blue cytoplasm and eccentric nucleus. Bone marrow findings, it is hypercellular. Presence of more than 30% of myeloma plasma cells is diagnostic of multiple myeloma. Plasma cells present as large oval cells with abundant pale blue cytoplasm and eccentric nucleus. Plasmablasts, cells with prominent single nucleus or bizarre multinucleated cells may predominate. In bone marrow aspirate of multiple myeloma, normal marrow cells are replaced by plasma cells with multiple nuclei, prominent nucleoli and cytoplasmic droplets containing immunoglobulins. Next, there are other cytological variants which are produced due to dysregulated synthesis of immunoglobulins. One such cell is flame cells. This is called so due to its fiery red cytoplasm. Moth cells these are cells with multiple grape like clusters of cytoplasmic droplets. Next, there are globular inclusions seen. Cytoplasmic inclusions are called Russell bodies and nuclear inclusions are called Dutcher bodies. Peripheral smear shows RBC is normocytic normochromic anemia. Rolu formation due to increased immunoglobulins is seen. WBCs and platelets are normal. Clinical features, they stem from effects of plasma cell growth in tissues, particularly bones, production of excessive immunoglobulins, suppression of normal humoral immunity. As already seen, bone resorption can cause hypercalcemia. On one hand, it causes neurological manifestations such as confusion, weakness and lethargy. It can also cause constipation, polyuria and renal dysfunction. So, decrease in production of normal immunoglobulins is seen, which causes recurrent bacterial infections. Like infections is one of the cause of death in patients with multiple myeloma. And renal failure is seen in about 50% of patients with multiple myeloma. The cause for renal failure is multifactorial, but the most important factor is Bence-Jones proteinuria. This is nothing but the excretion of light chains in urine. Certain light chains can cause AL type of amyloidosis, which can exacerbate renal dysfunction and can deposit in other tissues as well. So, serum protein electrophoresis of multiple myeloma shows M spike, which is due to monoclonal immunoglobulins detected as abnormal protein spikes in urine or serum electrophoresis. So, the most common monoclonal immunoglobulin produced is IgG followed by IgA. Next is clinicopathologic diagnosis. This relies mainly on two things. One is identification of clonal plasma cells and the other is presence of CRAB criteria. The C in CRAB stands for hypercalcemia, R is for renal dysfunction, A is for anemia and B is for bone lesions. So, the disease shows variable prognosis with median survival of 4 to 7 years. Translocations involving cyclin D1 usually have a good outcome, whereas deletions of 13q, 17p and translocation between 4 and 14 chromosome show an aggressive course. Myeloma cells are sensitive to proteasome inhibitors. Proteasomes are cell organelles that degrade unwanted and misfolded proteins. If misfolded proteins are not degraded properly in proteasomes, they trigger apoptosis. As we know, in multiple myeloma, there is an unbalanced synthesis of heavy and light chains of immunoglobulins. So, using this vulnerability of the proteasomes, proteasome inhibitors induce cell death and they also seem to retard bone resorption through effects on stromal cells. Next, let us move on to hairy cell leukemia. Hairy cell leukemia, this is an uncommon neoplasm of small mature B cells. It derives its name due to appearance of leukemic cells having fine hair-like projections around them. Morphology, peripheral smear shows pancytopenia. RBCs are normocytic and normochromic. WBCs are leukopenic with few hairy cells. Platelets are reduced in numbers. Bone marrow aspiration is difficult because the cells are enmeshed in an extracellular matrix of reticulin fibrils. So, it may turn out to be a dry tap. Hairy cells may be seen and reduction in myeloid, erythroid and megakaryotic cell lines are seen. As for immunophenotype, hairy cell leukemias typically express all B cell markers like CD19 and CD20 and other relatively distinctive markers include CD11C, CD25 and annexin A1. Clinical features, it presents with massive splenomegaly, pancytopenia and increased incidence of atypical mycobacterial infections. This hairy cell leukemia follows a lazy course. The reasons are unclear for why it is very sensitive to gentle chemotherapeutic regimens which produce long lasting remissions. Tumors often relapse after 5 or more years, but are still sensitive to the same regimen with which it was previously treated. This is a very unusual characteristic among other human cancers. And that is it for this video. Thank you. Have a nice day.